Let's now move on to the shoulder. The shoulder is comprised of the humerus, the head of the humerus. The scapula has both the glenoid portion that articulates with the humeral head, and also this is the acromion, which arises off the spine of the scapula, articulating with the clavicle. So this complicated complex of structures comprise the shoulder joint. Obviously, there's ligamentous structure stabilizing that joint capsule, and multiple ligaments holding together both the glenohumeral joint and the acromioclavicular joint. There's also ligaments holding together between the coracoid process of the scapula and the distal clavicle, the so-called coracoclavicular ligaments. This is a normal radiograph of the shoulder. We can see the humeral head, the glenoid, distal clavicle, and the acromion. This is the coracoid process over here. In this patient, here's the acromion, but look at that clavicle. It's riding very high up. Normally, it should sit down here, articulating with the acromion to form the coracoacromial joint. But in this case, there's been disruption of the ligaments at the acromioclavicular joint, and so the distal clavicle now will rise high. In addition, the coracoclavicular ligaments, the ligaments between the coracoid process and the clavicle, has been disrupted, allowing distal clavicle to elevate. So this is the so-called acromioclavicular separation, and this is specifically a type 3 when you have disruption of both sets of ligaments at the AC joint and the CC joint. It's a type 3 AC separation. This is an example of a fracture through the mid-clavicle. Very common injury and pretty obvious. Multiple fragments, comminutal fracture. And this is a fracture through the main portion of the scapula. You can see a fracture that involves the glenoid articular surface. A fracture extends into the body of the scapula. The importance of this injury is, if you can imagine, the scapula sits very close to the torso, very close to the chest, the thoracic cavity. If there is so much force traversing the thoracic cavity that we now have resulted in a fracture of that scapula, which is a very strong bone, imagine what has happened to the rest of that force. The force would dissipate, and you have to be on the alert for any secondary injuries, any injuries specifically of the mediastinum, of the aorta, injuries of the lungs that we should be aware of. Patients with injury of the main body of the scapula are at higher risk, higher association with mediastinal injuries. So in this patient, here is the glenoid, and here is the humeral head. If you remember, the humeral head will articulate with the glenoid, so it should be sitting over here usually. So there has now been a dislocation of that humeral head with respect to the glenoid. This is the so-called anterior dislocation of the humerus. So the glenoid is sort of like, if you play golf, this is like a tee, the golf tee. This is the golf ball that's sitting on the golf tee. When there has been an anterior dislocation, the golf ball gets driven into the front edge, the anterior lip of that golf tee of the glenoid. And the glenoid is very strong. It can actually take out a part of the humerus, causing a depression fracture, a deformity of the humeral head. And this deformity is the so-called Hill-Sachs deformity. Now, you can have an accompanying injury as well of that glenoid. The glenoid can also get fractured, and that's the so-called Bankart fracture. But it's the Hill-Sachs deformity I'd like you to pay attention to. So another patient where the humerus is sitting anterior to the glenoid. And look at this huge deformity, huge defect at the posterior lateral aspect of the humeral head. That's our Hill-Sachs deformity. It got formed because the anterior inferior lip of the glenoid chipped off a big defect of the humeral head.